This meeting is now being recorded.
Well, good evening or good afternoon. Welcome to the EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speakers, we'd like to give an overview of our free program for those attending for the first time. So we'll go over who we are, what is our program, some upcoming events, introduce our speakers from Paris, Dr. Hamonet and Dr. Brock, and looking forward to their presentation. Then we'll have a Q&A. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, who's also on the call, leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS hypermobile in 2008, the same year my wife, Carol, passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. We introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 100 groups to date. Each group is given their own free website with a link from the directory and map. We receive feedback that conferences provide valuable information and social opportunities that many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Tuesday, typically at 7:30 Eastern Standard Time, and we made the exception today. All of the programs are free. The meeting announcements and wherever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. This presentation is sponsored by Body Support Store, where you'll find over 250 products selected by EDSers for EDSers. The store is only funding for the program and usually covers our monthly web fees. Please visit our store and check out the helpful products that we offer. Just a brief disclaimer. This presentation contains general information about EDS. Members of the EDS community voluntarily participate in the program. The information is not advice. If you're having medical problems now, please call 911 or the emergency services in your location. Always consult your doctor before making any changes to your treatment.
Mark your calendars for our next webinar held at a special time, November 22nd at 1 o'clock Eastern Standard Time, which is 1900 CET in Europe. Our speaker will be Dr. Marco Castori from Rome, Italy, and he will be presenting multidisciplinary diagnostic and management approach to the EDS patient. To view upcoming speakers, see the webinars page at edsawareness.com for the full schedule. For those attending live today, there will be an opportunity for Q&A after the presentation. Please add your questions at any time by clicking the Q&A icon at the top of your screen. After typing in your question, click the orange button to submit. Tonight's presenters are Dr. Brock and Professor Hamonet, and their topic is a French perspective on Ehlers-Danlos. Professor Hamonet is a medical doctor in Paris, France. His specialties include physical medicine and rehabilitation, sports medicine, occupational medicine, and forensic medicine. He has a PhD in social anthropology, where his thesis was disability and anthropology at the University of Paris. He's a past professor of rehabilitation medicine at the University of Algiers and past associated professor at the University of Kansas in the United States. He is also past dean in the Faculty Department Communication and Social Inclusion at the University of Paris and past director of the National Reference Center for EDS, as well as consulting physician for Ehlers-Danlos at 2 hospitals during the time span of 1998 to 2016, with 3,000 patients diagnosed with Ehlers-Danlos. The European Rare Diseases Organization awarded him into their Hall of Fame in recognition of his rare disease research on EDS. And that's all we could fit on this slide. He's had many more accomplishments, so please do see his bio on our website to read more about everything that he's done for EDS and in different positions that he's held. And I'm going to move on to our second speaker, Dr. Brock. She was awarded her medical degree in October 2014 and started working as a clinical researcher under Professor Hamonet at the Hospital Hotel Dieu in Paris. And her research includes available treatments, efficacy, as well as diagnostic criteria for EDS hypermobility type. And having been an upper stage manager while gaining her university degree, she's fluent in 5 languages. She also organized and stage managed the international conferences on EDS in Paris in 2015 and 2016. Dr. Brock is now the clinical project manager for GERSED. This study and research group for EDS currently consists of 69 physicians from all over the world. It is an association open only to medical professionals interested in furthering research on EDS and conducting clinical trials to do so. So it's my wonderful pleasure to introduce our speakers from Paris, and we really appreciate you taking the time and to do this for us. It's an international effort, and we're so pleased with all the accomplishments you've made in your country and that you're able to share those with us. So I'm going to go ahead and load the slides for your presentation and turn the microphone over to you, Dr. Brock.
We are very honored to be here and to be able to speak to you all. Thank you for inviting us. Professor Hamonet is sitting right next to me. I will be the one speaking because it is in English, but he would love to introduce himself a bit, and I'm going to try and translate it.
Hello, I am very happy to work with your group, a very interesting group. Alors, il y a plusieurs années, près de 18 ans maintenant, que je travaille avec des patients qui ont le syndrome d'Ehlers-Danlos.
It has been now 18 years that I have been working with EDS patients.
Mes premières rencontres ont été avec des patients que les médecins m'ont adressés quand j'étais chef de service en médecine physique réadaptation dans un hôpital universitaire parce qu'ils ne comprenaient pas pourquoi ces patients souffraient autant et se plaignaient d'autant de symptômes.
His first encounter 18 years ago was at a university hospital here in Paris, where he had been sent patients with EDS, diagnosed with EDS, and the physicians asked him to please have a look at them, find treatments, and understand why they had so many symptoms they complained of.
Parmi les symptômes et les signes, il y avait 2 signes connus pour être dans le syndrome d'Ehlers-Danlos, l'hypermobilité et l'étirabilité de la peau.
Within all those symptoms they presented with, there were 2 signs that were known to be EDS signs, which were hypermobility and the stretchability of the skin.
Mais j'ai trouvé aussi beaucoup d'autres signes au niveau de la vessie, au niveau des oreilles, de l'audition, au niveau du tube digestif, des organes génitaux et surtout une très grande fatigue et des douleurs extrêmement difficiles à traiter.
But he has found, listening to these patients, a lot of other symptoms, genitourinary, ORL, so ear, nose, throat, all of these symptoms, but also and especially great fatigue and a lot of pain.
J'ai de cette façon pu décrire ou redécrire la clinique de ce syndrome qui était fort mal décrite jusqu'à présent, puisque limitée aux deux signes que je viens de citer.
This is how he has been able to reintroduce and to look at this disease in a different manner, listening to the patients and introducing all of these symptoms the patients complained about, and not only the two signs and symptoms he had talked about earlier.
J'ai écrit cette nouvelle description, ces signes, dans un site destiné à mes étudiants, de façon à ce qu'ils puissent faire le diagnostic, ce qui n'était pratiquement jamais fait chez les patients que j'ai rencontrés.
He had written down the signs and symptoms onto a website for his students to learn about all the other signs and symptoms that seemed to be connected, which had never been connected beforehand.
Mais je ne savais pas qu'en mettant un site universitaire sur Internet, je recevrais autant de patients qui ont découvert le site au hasard des symptômes, des signes, et qu'ils ont placés sur Internet en arrivant de cette façon directement sur mon site.
But what he didn't know was that by actually putting all these signs and symptoms for EDS on this website, purely for his students, that all the patients, because it was internet, could find these signs and symptoms and actually come to him via that website only by chance. He wasn't aware of that.
En effet, ces patients, vous êtes très nombreux, et ce n'est pas une maladie rare, c'est une maladie en fait plutôt fréquente, et actuellement, j'ai vu personnellement et diagnostiqué plus de 3000 personnes.
And you, the patients listening in, need to know this is not actually a rare disease. It is a lot more frequent than we think, and up until today, he has personally seen and diagnosed 3,000 and above patients.
Les résultats que je vais vous montrer viennent de ce qu'on appelle une cohorte de patients, de 2600 patients qui ont été suivis par moi-même à l'Hôtel-Dieu de Paris dans une consultation spécialisée.
The signs and symptoms he is going to present come from a cohort of patients, 2,600 in total, that have been seen at a specialized consultation at Hôtel-Dieu de Paris.
Je sais très bien que l'on discute l'existence de différentes formes dans ce syndrome, qui est une maladie pour moi, en fait, plutôt unique, avec le même mécanisme, qui touche tous les tissus de notre corps, ce qui explique la multiplicité des signes.
He knows well that EDS is put into different categories. For him, it is more a homogeneous group where all the tissues in the body are affected and all the different groups do present with common signs and symptoms.
La description que je vais vous donner concerne la forme qui de très loin est la plus fréquente. C'est pratiquement la seule forme que nous rencontrons dans nos consultations spécialisées.
The signs and symptoms we are going to present today are the signs and symptoms for the by large most common form of EDS and the form that we see the most at our hospital.
On l'appelle maintenant, surtout depuis la réunion de mai dernier à New York, la forme commune, parce que très fréquente, systémique, parce qu'elle touche tous les tissus, tous les organes. Elle a aussi été appelée hypermobile, ce qu'elle n'est pas toujours.
The form as of New York this year in May 2016 is now often called common because it is frequent, systemic because it is a systemic disease, and it is the former known hypermobile form, which it is not always. Not every patient needs to be hypermobile to be EDS-HT.
Positif suivant.
Merci. Moi, je vais parler maintenant?
Oui.
Okay. I am going to start the presentation of the slides now, and so that it is faster, we suggested that I speak through in English, but the professor is sitting next to me, and I am presenting the presentations he normally gives to medical professionals and patients throughout the planet. So, what is Ehlers-Danlos? Ehlers-Danlos, if you listen to it in French, many people say l'air dans l'os, which is you have air in your bones. No, it's Ehlers-Danlos. I have a very stretchy skin, or if I'm a contortionist, that's not really it either. What we do know is that it is not very well known, but it is very frequent. Most suggest that it's 1 to 2% of the population. But it has been very badly described. It started off actually in Moscow in 1881 by a physician called Tschernogobow, and then by Ehlers in Copenhagen in 1900. Danlos himself seems to have made a mistake and confused the patient who had pseudoxanthoma elasticum, which is the very, very stretchy skin. And he described one patient. Ehlers just said there's a loose skin, it has hemorrhagic tendencies, and the articulation, so the joints are very loose. And he described that in 1900.
Sur cette slide, enfin, sur cette image, vous apercevez Ehlers, mais aussi une peau étirable. Elle n'est jamais très étirable. Elle est nettement, mais pas autant que dans l'os à décrit, dans son erreur en fait de diagnostic. Et l'hypermobilité qui n'est pas toujours aussi spectaculaire. Et il a décrit le troisième signe important, déjà, dès 1900, c'est-à-dire les ecchymoses, les hémorragies.
You see Ehlers himself here, and you see a stretchy skin, but it doesn't actually have to be this stretchy to be positive for EDS. You see hypermobility here, also very hypermobile. It doesn't have to be like that in every patient, and Ehlers himself already described the hemorrhagic tendencies, which you see here. Finally, in 1933, Ehlers and Danlos were joined by Achille Miget, who wrote his thesis, his doctorate thesis in medicine in Paris, and joined Ehlers and Danlos together, and since then it was called Ehlers-Danlos syndrome, but the Russians actually kept Tschernogobow syndrome.
Par la suite, après la description par les dermatologistes, les trois personnes citées étaient dermatologues, ce syndrome a été repris par les rhumatologues.
EDS had first been described by dermatologists. All three of them were dermatologists, Ehlers-Danlos and Tschernogobow. But the rheumatologists and the geneticists in the 1950s actually took up EDS because the dermatologists abandoned it.
Malheureusement, ces rhumatologues qui étaient intéressés avant tout par l'hypermobilité ont décrit une hypermobilité articulaire bénigne, c'est-à-dire sans véritable gêne comme une autre façon d'être normal.
Sadly, the rheumatologist first introduced the joint hypermobility only by hypermobile joints and said it is benign and that there were no other problems with it, as though it is just a small difference towards normal people.
Malheureusement, cette idée persiste beaucoup dans l'esprit des médecins, pas seulement les rhumatologues, qui considèrent que ce n'est pas une vraie maladie, que c'est plutôt une curiosité et que cela ne doit pas donner de difficultés pour vivre. C'est évidemment une grande erreur.
Sadly, this error is what has stuck in the heads of the rheumatologists, often is stuck in the head of the rheumatologists, that this is a benign disease, a small curiosity, and that the patients aren't really suffering of anything.
La troisième partie de l'histoire de cette maladie est liée aux généticiens, initialement Bayton. L'objet des généticiens est de chercher une différenciation entre différentes formes de cette maladie à partir du collagène, des variations du collagène.
The geneticists went a different way. They found different mutations and classified EDS by these mutations and not by the symptoms.
Pourquoi les généticiens? Parce qu'on s'est aperçu que cette maladie était héréditaire. Et ceci avait donc comme conséquence la recherche de gènes. Actuellement, dans la forme dont nous parlons, la forme de loin la plus fréquente, on n'a pas trouvé de gènes. Le diagnostic sera donc uniquement clinique.
But the problem is that the geneticists haven't actually found the one mutation for the most common form, which is EDS hypermobile, but it is still a genetic and familial disease. So, positive diagnosis is at the moment solely based on clinical signs. There is no biological marker, at least not a genetic one. There's a cutaneous biopsy. It is it's sometimes not well supported by the patients. It is practiced in Belgium, and it shows non-specific alterations in the connective tissue. That includes EDS hypermobile type, which is a very good thing for those patients that keep being told it's all in your head. Then there's the familial argument, which is very important to ask for, but within one family we observe very diverse signs and very diverse symptoms. So if you have a patient or if you have a friend, there are 8 clinical signs that should put you on alert to actually check for EDS. The first sign is the door sign, which is a proprioceptive problem. That is patients that have a tendency to bump against the door frame, although they perfectly well see the door. The second sign is the sign of the sock, which is cold feet, even in summer. That comes from dysautonomia. The third sign is the sign of the car door, which is that you get electrical shocks when you touch the car doors, which comes from a very fine skin. The fourth sign of the stairs, is an exertional dyspnea, so shortness of breath whilst walking one flight of stairs is a proprioceptive problem, and patients tend to have that without actually having any heart disease. The fifth sign, the sign of Miget, which is ecchymosis after taking blood, even if somebody tells you, no, I'm perfect at taking blood, but you still will get ecchymosis. The sixth sign is the sign of the etiquette, which is patients tend to tell us, I have to take out the etiquette out of my pullover because it drives me nuts. Seventh sign of Coq-à-l'âne, which is patients with attention deficit or even diagnosed with ADHD because they jump from one subject to the next and so forth. And the eighth sign, we call it the sign of the post-it because working memory isn't always the best and they put post-it everywhere. So what are the two pillars for clinical diagnosis? signs and symptoms. There's pain, there's fatigue, there's a decreased proprioception. I like one, show presenter person here. I hope you can see my arrow now. Down here I put one publication which is very interesting. There are a few publications out about proprioception, but this one speaks about proprioception which is accurate but not precise, which means patients, when they have the finger to nose test with eyes closed, they will be somewhere close to the nose, but they will never hit the nose. It's not precise. But it is accurate, which means they don't hit their forehead the whole time. Then there's hypermobility, of course, we know that. We will come to it later. There's cutaneous fragility and dysautonomia. There are the hemorrhagic tendencies that don't only involve the skin. You also have children that have frequent nosebleeds in childhood, or when you brush your teeth, patients tend to always bleed when they brush their teeth, although everything's perfectly normal with their teeth. There's hypersensoriality, which is that patients have a tendency to say, sometimes I hear a lot of noise and it drives me nuts, although it's not actually very loud, or they have very good noses. Some patients have a tendency to even take jobs in perfume development and so forth. Then there's visual fatigue. So reading a few pages, the eyes get very fatigued very fast. Then there's respiratory symptoms, blockages and dyspnea, so shortness of breath, as we are going to explain further, and the cognitive problems we talked about. And then, because this is a connective tissue disease and it is everywhere in the body, because connective tissue is everywhere in the body, you get reflux and constipation and meteorism and dysuria and buccal manifestations and dyspareunia and problems during labor, and it goes on because it's a connective tissue disease. All these signs and symptoms do not have to be there at the same time. The point is to ask a question about the whole life, and not only do you have all of this on the same day. Some people do, but that is not the point about EDS. The point about EDS is that patients go to different physicians for different problems throughout their whole life, and nobody can diagnose it because they go to so many different physicians, which is correct from their point of view. We have found a link to autism spectrum disorder and Asperger and learning disorders, which seems to be more, and we come to that when we get to treatment, more to the fact that autism might have a problem with proprioception and EDS has a problem with proprioception, and that might be an overlap. And obviously the hereditary character that we know. So these clinical manifestations, they have their origin in the alteration of the mechanical characteristics of collagen. We know that from the geneticist, it's collagen mutations, and it changes the mechanical aspects of the connective tissue. One is the tissue fragility. It alters the reactivity to physical stimuli, and that disturbs the messages that actually get to the receptors. The receptors are working and the nerves are working, but they are disseminated in the tissues that are mutated. And then there's dysproprioception, which is not properly working proprioception. Proprioception is a word that explains the perception of one's own body and the knowledge of where the body is in space. So these patients are very vulnerable to any environmental stimuli because they get so many of them and they are so sensitive to them that there's an overload. And medications tend to sometimes work differently in EDS patients. That is, their efficacy might be higher or lower, and we never know what happens until we actually try it out. And side effects are sometimes a lot more frequent than with other patients. So how do we test for hypermobility? The Bison test has 9 points in total. Diagnosis is at 4 or 5 points out of 9, depending on whether you have the Brighton or the Villefranche criteria. For being able to put your thumb, it doesn't have to completely touch, but for being able to put it this far, you get 2 points, 1 for each hand. If you can put your fifth finger at 90-degree angle, you get 1 point for each hand. If you can curve it, your elbow for more than 10 degrees, you get 1 point for each arm. And then if you can touch the floor with your flat hands, you get 1 point for that. But there are other signs that show that a patient was hypermobile. For example, if you can put your hands behind your back and actually pray the other way around, you're hypermobile because you need your scapula to detach this way. That is also hypermobility. It's not in the Beighton test, but we know that Beighton is not always the best test to look for hypermobility, and you can look for hypermobility in other joints. What we see on the right-hand side here is that often patients are able to put their foot to their gluteal region with no problem, but the other way around, they have retractions already at this angle, although they are normally hypermobile.
Cette constatation de rétraction, c'est-à-dire le contraire de l'hypermobilité, ne doit pas faire rejeter le diagnostic.
Which is very important because the fact that patients can have retractions is so contrary to being hypermobile that some physicians reject the EDS diagnosis because patients have retractions, so shortenings of their muscles and tendons, although they actually have EDS.
Surtout si on la trouve chez un jeune enfant. C'est même, pensons-nous, un signe en faveur d'Ehlers-Danlos.
Especially if you find it in children, which are normally a lot more mobile than adults, even if they don't have EDS. If you find it in a child, it should alert you to having EDS because the retraction seems to be a consequence of the body against the mobile body.
Donc l'hypermobilité est un signe très fréquent, mais il peut y avoir des rétractions.
So hypermobility is a very frequent sign, but there can be retractions, shortening. There's another test that one of our physicians here in Paris has found, Dr. Isabelle, so we call it the Isabelle test. It looks for hypermobility in the shoulder. The shoulder normally uses the scapula above 90 degrees angle. So we block the scapula with one hand and then move the shoulder above 90 degrees. And in a hypermobile patient, the scapula down here will only move above 90 degrees, which is always pathological.
Ce signe n'est pas décrit dans la liste de Beighton, qui est centrée surtout sur les articulations périphériques.
And this sign is not described in the Beighton test, which centers more about the peripheral articulation.
Et pourtant, les difficultés avec l'épaule sont très importantes chez les patients qui ont ce syndrome.
But many patients with EDS have great problems with their shoulder and shoulder girdles. There's also one retraction, which is the retraction of the triceps, which is very common and which makes for pain in the feet. Then we come to the tissue fragility. Surgery can give delayed and very anesthetic, sometimes anesthetic wound healing. And this is not actually about the stretchability of the skin here, but about the scar, the long, long scar that you see here. It was a decompression incision because this patient has been given anticoagulation, heparin, and in order to prevent the compression of the nerves and vessels in the shoulder, they had to decompress, and this decompression incision had to go further and further and further, and at the end left this long, long scar because of the delayed and improper wound healing in EDS.
Cette patiente avait été mise sous traitement anticoagulant, ce qui avait provoqué une énorme hémorragie au niveau du bras et de l'avant-bras. Et le chirurgien qui était chargé de l'amputer au niveau de l'épaule a préféré faire ce traitement qui a réussi très bien.
So after having been given the anticoagulation, the whole upper arm got full with blood, and the surgeon who was in charge of actually amputating the whole arm preferred to do a decompression incision, leaving the scar, but at least also leaving the arm intact. Then what we often see are striae, which is the cutaneous fragility, and they come before pregnancy. They sometimes come before puberty, which is a sign that should alert. Then there are the luxations. You see here the luxation of the shoulder. And the most important thing, don't do surgery, because it can just simply auto-reduct. Because stabilizing surgery doesn't always work. So the connective tissue is not very strong, it's unstable. So if you try to do the surgery, the luxation is still there afterwards, because the surgeon can't actually find any tissue where it can stabilize with. We had one surgeon who thought the 17th operation might then help. It obviously did not. And often surgeries obviously leave not so nice scars. Then there's the EDS foot. We see it. Professor Bravo in Chile has a lot of very nice pictures about it. There's a luxation of the short lateral peroneal tendon, and there's a false high-arched foot, but there's a true flat forefoot, which you see here. And we will come to that because treating this foot is very, very important. Scoliosis is frequent. It is non-evolving, and it is just simply there. It's a mild scoliosis, but it doesn't necessarily need treatment. Which is, you see here that this side is higher and this side is
Dans
lower.
quelques cas, il y a des scolioses évolutives qui doivent être traitées par orthèse, mieux que par chirurgie.
And when we will come to the treatment afterwards, there are a few cases where the scoliosis is very apparent, but it is better to treat it the way we will show you than to do it with surgery. Then, as you can see here, because the tissues are loose, you can see here and you can see here that the teeth might just grow into every direction because they don't stuck, and the TMJ joints, they can luxate by eating sushi, things like that. Then there's a sign that we quite often see, that's Gorlin sign, which is the possibility to be hypermobile with your tongue really and touch your nose with your tongue. Clinical exams that should be done once you have diagnosed EDS is that all EDS are basically vascular. That is to say, all EDS can bleed, and we do echoes on each and every one of them. If there is a family history of any aneurysms or cerebral hemorrhages, we actually follow up with an angio-MRI of all the arteries. Once this has been done and the echo has been done, if nothing is found, that is okay, and otherwise it has to be followed up. Then we do on every patient ultrasounds of the gallbladder, because gallstones are frequent just simply because the gallbladder is very stretchy, and therefore you can get stones, and if these stones you don't feel the pain because the gallbladder is so stretchy, it can then lead to peritonitis and gangrene. We do cardiac echoes because you see valvular insufficiencies, but in most cases there are no consequences. to it. The professor always says the heart is the most solid organ in EDS, even when there's tachycardia and things like that, that the patients feel that the heart seems to be the most solid organ. And then we have started to do upright MRIs of the cervical spine to look for anarchy malformations. Then there are the signs. Cysts are very frequent and nodules as well. That is just simply a connective tissue that is stretchable. Infections like otitis media in children and allergies are more frequent. We have started to do research on MCAS, which seems to be associated because mastocytes seem to be overactive, which then leads to that tests for inflammation, CPK and so forth can be positive. When there are signs of anemia and hyposideremia or low hemoglobin, so low blood levels, it's just simply an expression of the chronic bleeding that is not necessarily a vascular EDS, because every EDS can bleed. That's the part of the diagnosis. And so the problem now is what you do, because the most important part is actually to treat and to alleviate the problems that are there. So the treatments that we are proposing have been tried out on more than 3,000 and followed up on more than 2,600 patients, especially over the course of the last 9 years at Hotel Dieu de Paris. That's a hospital in Paris right next to Notre Dame. So what we see and the treatments we're giving, they are innocuous, and we keep listening to patients. We have 1 and 1.5 hours to see the patients, and the professor is this great clinician who knows how to listen to his patients. And when they came up with something that helped them, and then another one came up with the same thing, he tried out and looked where it got them. And so treatments in Paris and their efficiency are also seen as a contribution to a positive diagnosis, because if the treatment works, then it's the right direction. About this. So, when you have the physiopathology to the treatment, there are 3 therapeutical goals. And the professor comes from a disability and handicap issue. So fatigue is a problem, and it needs to be fought against, because when you are really tired, you might not be able to go to work. So it needs to be fought against. When you're really tired, you can't listen in school, so you need to fight against that. Okay. I hope you can still hear me. Yes, it looks as though. The second thing is to correct the proprioceptive problems, because when you correct them, you fight the fatigue, you fight the pain, you fight the proprioceptive problems, and you fight a lot of different things altogether. And then the pain needs to be relieved so that people can actually live better. First thing off, fight the fatigue. We are very fortunate in France that we can give oxygen therapy even if somebody does not fall under 90% saturation. We give it each day between 1.5 to 5 liters per minute, 20 to 30 minutes, twice a day or more if needed. I will show you pictures of the oxygen extractor that is being used here later. Then Dr. Chopra in the US and Professor Hamonet here both use L-carnitine in children as well as in adults, and adults can just simply have a higher dosage. L-carnitine uses fat and puts it into amino acids, which can then be used by the mitochondria to make energy. So here's the oxygen therapy. I'm going to put the arrow back on. You get oxygen, you can take it anywhere, you can have it sitting at home, you can use the oxygen therapy, the 20 minutes whilst you're watching telly, for example, or when you eat breakfast or whatever. We often actually also give it to children in school, so that they have it at school. When they get very, very tired, they are allowed to go outside of the classroom, take oxygen therapy, and then they can go back in, because it is more important to actually have them join school and be there than not having the treatment possibility. We have done different research and studies on oxygen. This one is on 124 patients. Remember, although it is not a rare disease, it is being treated as a rare disease. So 124 patients is actually quite a lot. As we can always see, more patients are female, not because genetically they get it more often, but just simply because they are more symptomatic, which seems to be a problem of the receptors being very sensitive to estrogen. So there is a very significant effect of getting better with oxygen, 30% of patients, and a significant effect of 26%, which 56% with good or very good results and getting people back into work, I think it's worth doing it. It also, for migraines, it also fights the fatigue. 50% efficiency are very efficient. So this is not about not being fatigued at all anymore. This is about being less fatigued so that you can do something during the day.
Nous pensons que ce n'est pas le manque d'oxygène dans le sang qui est responsable de cette fatigue ou des difficultés autres, essoufflement, etc. Mais c'est le fait que la diffusion de l'oxygène au-delà des petits vaisseaux vers les cellules, notamment les muscles et aussi les cellules du cerveau, les neurones, qui est déficiente. En ajoutant l'oxygène, on corrige cela.
We think there's no problem in actually getting the oxygen from the lungs into the blood. That doesn't seem to be the problem. Most people have a normal saturation if they don't have any other problems. The problem seems to lie on the fact that the extraction or the diffusion of oxygen at the capillary level is impaired. And so if you give more oxygen, it overcomes that extraction problem, and therefore the cells actually do get enough oxygen, which is the breathing issue where 58% shortness of breath, it becomes very efficient. How do you correct the proprioceptive problem? One thing is orthesis. So here we come to it. The feet have a lot of receptors for proprioception.
Juste revenir en arrière pour dire un mot sur le rôle de l'oxygène dans les migraines, qui est très important. L'efficacité est de l'ordre également de 80% dans les migraines. C'est très important parce que ces migraines sont souvent très fortes dans le syndrome.
Just to come back to something I neglected to say, oxygen seems to help a lot with migraine, and migraine in EDS seems to be very severe and very disabling. And so oxygen, when given early enough and when it starts, seems to alleviate that by a very big margin. So the plantar retractions, there are a lot of receptors in the foot that tell the body where we are in space. And if you see here, the flat forefoot means that these receptors here and the high arch are not really working because they don't touch the ground properly. So what we do, we put orthesis into the shoes individually, corrected for it, to correct exactly this problem. Then there are a lot of people that have luxations in the hands itself and in the wrist. So because EDS is very fragile, it needs to be a very light orthesis, and so that the patients with that orthesis, which is cut off here, can still write or type, but where the wrist stops luxating. As well as where you see here, it goes over the thumb, because the luxation here at the thumb joint is quite often and quite debilitating when it happens, because it doesn't easily go back in. Then the instability of the spine and the instability of the shoulders can be alleviated with a Spanish orthesis called El Cross. What it does is it gives you 3 points here and here that hold back the shoulder, straighten your spine, and in here it holds your spine stable. It is also very good against meteorism, because it actually closes well in front and keeps your stomach straight.
Cette ceinture très intéressante donne des informations au cerveau sur la position du corps, 2 points en avant au niveau des épaules, 1 point en arrière au niveau du bas du dos.
So it's these 3 points here in the shoulder that straighten the shoulder back and down so that it stops luxating, and it goes to the 3rd point down here, which then keeps your back in place whilst walking, for example. K-taping, I'm quite sure you do know that also in the US, and it can be done very easily. It can be used anywhere for luxations, for example, in the shoulder. What it also does is it gives the body back sensations of where it is in space, under the foot, or anywhere where the problem is. There's one thing that is very special because it was invented in France. I'm going to talk about the possibility and how Dr. Chopra implements it for the US. But what has been invented by Professor Hamonet in France is the compressive garments. What they do is they are individual for every EDS person. They are breathable because EDS patients don't seem to have any temperature regulation, and they are very compressive to the body itself. They give back the sensation to the body where it is in space, so it goes, it re-educates the brain of where is my body in space, which means less luxations and less pain. It also gives less pain because it is actually compression and pressure on the body is an information that travels faster than pain to the brain, and therefore by gate control theory you will only feel the pressure because the pain is just simply slower to get through the brain, and therefore it can't get there. So it alleviates pain, it alleviates luxations, it re-educates the brain of being not so clumsy and not hitting against the next table again, and it fights fatigue as a consequence, because if the body doesn't have to recheck where it is in space because it actually knows where it is in space, you get less fatigued. Now, the insurance companies in France pay for it. It is fully covered and everything, but you don't have it in the US yet. What Dr. Chopra does is he tells his patients to go into a very good sports clothing factory or shop and buy sports clothes that are very tight to the skin, and just simply buy them one size smaller. It needs to be sports clothes, in our opinion, that are breathable, because EDS has temperature and sweating problems. At least that would be a way for you in the US to do it, and it is better than nothing, I think. For the hands and for the feet, you can have the same orthesis on the feet. On the hands, we've now done it in such a way that you can grip better, because if you don't have that, it falls through your hand. So we put these little things on it. And here, this is an orthesis that is just for the thumb again, and to stop the luxation of the thumb, for example, whilst writing or gripping anything. Then, as we said beforehand, the shoulders are frequently very unstable. This is called the Montreal scarf. It wraps around the back here, goes behind the back, comes up here, goes around here, and touches there. It is, for example, something else to do than the L-cross girdle, and it is something that you could do at home when your shoulder is luxated. You can do it with nice garments or scarves, and it re-educates it. When it comes to those where the compressive clothing is not enough anymore to walk, and we have certainly a lot of patients that are in wheelchairs, and we want to get them back into walking, we give them the compressive clothing, try that out, and if it's not enough, then on top we give exoskeletons that need to be very light because of fatigue and muscle fatigue and so forth, and that are just for the joint that keeps luxating. What we have seen is that we only put it often on just one hip in EDS and not on both, because it makes the EDS person more stable, and it's enough for them to restart walking, and the hip doesn't luxate as much. If you put it on both sides, sometimes EDS just keeps luxating from one side and then to the next, so it seems to be working better just from one side.
Cette orthèse, avec pièce de hanche, empêche la luxation de la hanche, qui est très douloureuse et qui vient bloquer, interrompre la marche. C'est un traitement très efficace.
So it stops the hip from luxating, which is one of the very, very painful luxations, and which, when the hip is luxated, obviously walking doesn't work as well anymore, and just putting it on one side gets people out of wheelchairs and back into walking, which gets them back into some form of exercise, which brings back a little bit more energy and fights fatigue and so forth. And then we actually have people that without the orthesis they couldn't do it, and now she's jumping, well, the horse is jumping with the orthesis on. What we did have to do was make the orthesis a little bit different down here for the horse's sake, but otherwise it works very well, and she's actually gaining some medals together with her horse. So when scoliosis goes worse than the two pictures we've shown beforehand, it needs to be addressed. It is better to address it with rigid braces than with surgery, because we know surgery can go wrong out of so many reasons. One, it's unstable anyway, and bleeding issues and wound healing issues and so forth. So first and foremost, try and put rigid braces on and write the scoliosis again and get people back into working.
Souvent, ces patients aiment bien avoir des orthèses plutôt rigides. C'est surprenant, mais ils se sentent plus en sécurité, il y a moins de mouvement, donc moins de douleur.
Often our patients say that rigid braces make them feel more secure, because the hypermobility stops and the mobility stops, and it actually feels better to have a rigid brace or orthesis. So here we go in what can we do to get children back into school and into learning. If they can't sit for a long time, or they fall in their chair because they can't hold themselves up, we make them for them individually chairs that are adaptable. They can put a table on it. They have girths holding them in. The table is adjustable, and then we put cushions underneath that are decubitus memory foam cushions so that they can sit for a longer time without getting into pain. Also, to correct the proprioception, we need orthoptical evaluations and prisms to correct the visual proprioception. The point is to first do the plantar shoe inlays, then do the orthoptical evaluation and the correction of the vision, because the receptors of the eye and the feet go together to be able to walk correctly and know where you are in space. And then once the orthoptician says, we've corrected the vision, then get new shoes again. To correct the dysproprioception in the lungs for breathing, there's not only oxygen, but for those that are even worse off, there's an called percussionaire. It gives repetitive pressures, and they can't be too strong because obviously the lung tissue is also fragile, but it retrains the lung and the brain to understand how breathing in works.
Ceci est une des premières applications que nous avons faites pour traiter les problèmes respiratoires du syndrome.
This was one of the first applications we ever tried out to treat the dyspnea and respiratory manifestations.
C'est une invention américaine qui est due au Dr. Bird. Dr. Bird, qui est devenu un de mes amis sur le tard, maintenant décédé, a imaginé cet appareil pour traiter les encombrements bronchiques, et il a été très efficace dans le syndrome pour redonner des sensations bronchiques, mais aussi trachéales et pharyngo-laryngo, au niveau de la gorge et de l'ensemble du système respiratoire.
This is actually an American invention by a Dr. Berg, who has become a very good friend of the professor, and it was beforehand invented to treat bronchitis. And what it does in EDS, it gives back the sensations in the bronchioles, in the trachea, and in the larynx to know how this should be working, so that the body understands again where and how it should function.
Excusez-moi. Il faut dire à propos du Dr. Bird, qui est décédé récemment, mais très âgé, je crois 86-87 ans, qu'il a contribué à la libération de la France comme aviateur lors du débarquement de Normandie, ce qui est absolument extraordinaire. Et cet homme a inventé un appareil qui porte son nom, le Bird, qui a sauvé la vie de beaucoup d'enfants au moment de la poliomyélite respiratoire.
Dr. Berg, who is by now most probably 86, 87, has great value in France because he was part of the liberation of Normandy in the Second World War. And his apparatus, the Bird apparatus, was used and has saved a lot of lives of children with poliomyelitis. Other treatments for proprioception are dental orthesis for postural control, because again, there are receptors right behind your teeth that tell the body where it is in space. And you see often patients with EDS that push their tongue quite strongly against their teeth. It is a sensation to give the brain back where it is. Then we have seen there is quite often dystonia in EDS, and when treated with levodopa, 62.5 milligrams, which is 50 milligrams, and then 12.5 benzerazide, it actually does not only help the dystonia, but it fights the pain, fights the fatigue as a consequence, and it fights the luxations. Dystonia per se, by definition, is just simply involuntary muscle movements. And EDS patients need to be asked for it, and when they have it, and we have about 58% of patients that have it, when they are then being treated for it, it alleviates a lot of the other symptoms. Then a lot of patients have tachycardia, but the heart is the most solid organ, but there is tachycardia, sinus tachycardia, and sometimes even POTS. So our cardiologist, Dr. Amoretti, has looked at the different beta blockers that could treat tachycardia and has found out that bisoprolol for EDS is the best one at a very, very low dosage of 1.25 milligrams, maybe higher to 2.5 a day. And the tachycardia goes away with that without lowering the blood pressure. Then physical therapy. Physical therapy is very, very important. The point is that the physical therapist needs to understand that it needs to be isometric, which means don't do too much. The body in EDS does fatigue quite fast. You shouldn't go too far because sometimes that means that you go 5 steps back. Isometric, yes, it does take longer, but you will actually get to your goal. Hydrotherapy, Tai Chi, all of these seem to work quite well. Talk to the patients about it, and Tai Chi it's very soft movements again, but it is movement. And the muscles need to be stretched because the retractions often also make the pain and not the actual hypermobility. How to release pain. So what we are trying to do is that when patients come in on morphine and on all these different pain medications, the point is to get them down to being able to take acetaminophen again and that it works again. So we have all these different therapies that taken together will actually alleviate more of the pain than just one medication. It's a connective tissue disease. It's everywhere. You need to attack it from everywhere. One is the orthesis and the compressive garments we already talked about, which is a gate control theory. Fast pressure receptors give faster information than pain, and therefore the brain will only register the pressure and not the pain. Heat and massages help a lot to alleviate these retracted muscles that become very hard and they need to be massaged out, but not too hard again. There might be a bleeding issue. Long-term massage and heat. Lidocaine, in the States it actually comes up as a 4% gel over the counter. We have it here as patches in 1% lidocaine, and we give injections into the trigger zones and the muscles and near the tendon points that have tendency to become tendinitis. The very interesting thing about lidocaine is that when you do it with injections, it is immediately efficient. So if you see the effect immediately, it takes a minute to start, and the face of the patient really changes in being alleviated. And what is very interesting is that lidocaine should only work for an hour. It's got a half-life of an hour, but it's efficient for days, sometimes weeks, and sometimes more. So the patients come back after the effect has worn off, and then they get injections again. And with that, it seems to be more of a re-education of the brain of this is not pain, this is something else you're feeling, and therefore the pain goes away. Then there is the TENS, which is the neurostimulator, which works with the same gate control theory as the compressive garments. TENS is something that is being used in many different pain states. This is not in any way special to EDS, so your physicians will know about it. You apply it locally, and that is where the pain then will stop. And the good thing about it is that you don't have to take a medication that goes through the body. As long as you want.
Necessary.
As long as you want, as long as necessary, no problem with it.
Anytime.
And any time. And then cryotherapy, we've just been starting with it. It seems to be very efficient. we keep having, we look into it more and more. It goes to the re-educative aspect of it. So it's a cold shock to the system.
Quelquefois, cette cryothérapie est mal supportée, surtout avec de la glace. Mais il y a d'autres traitements avec des fluides qui sont beaucoup mieux supportés, qui nécessitent un équipement particulier.
Encore une fois, pardon.
Non, c'est bien. Donc, la cryothérapie locale est quelquefois mal supportée, notamment avec la glace.
But sometimes if you do it yourself, so just taking ice and putting it locally on your skin, that is actually not so well supported.
Mais il existe des techniques différentes de cryothérapie qui vont se développer et sont mieux supportées.
But techniques are being developed that are different than just an ice cube, that seem to be very well supported, and it's more of a very cold shock to the system, and then you get away from it. I'm going to answer some of these questions in the public chat that I keep seeing. Yes, the holding the breath issue is blockages, and it's a proprioceptive problem, and it needs to be trained away, for example, with the percussionaire, or with singing lessons, and things like that, or even the compressive garments have a tendency to re-educate the diaphragm and re-educate the brain of how to breathe, because you relearn where your body is. I have seen a patient actually in my first week, which was the most amazing thing I have ever seen in my life. She nearly couldn't speak. There wasn't enough air coming out of her lungs to make speech possible, short of breath, and then the professor used the lidocaine injections subcutaneously into the diaphragm trigger points, and a minute later this woman had a voice again. So yes, it does work, and it seems to be proprioceptive. So, how to relieve pain? Morphine doesn't seem to work that well. Obviously, patients come with it because nothing else does work at all anymore, but we really try to use the compressive clothing and or the lidocaine injections and the TENS and the re-education and so forth to get these patients slowly off of morphine, because it also has GI side effects that sometimes are bigger in EDS and so forth. Antidepressives are often given to patients, although they're not really depressed, they are just sad about nobody helping them. What antidepressives, and don't get me wrong, somebody who is really depressed should be on antidepressives, but EDS patients that shouldn't necessarily be on an antidepressive if it's the wrong diagnosis, because what antidepressives do is they have this tendency to dislocate the brain from the body, and therefore this whole understanding of the brain of where the body is in time, in space, gets worse and makes all the symptoms of EDS worse. No aspirin, obviously, hemorrhagic tendencies. There are other pain medications that can be used. Acupon, which is Nifopam in its generic name. I'm not sure whether it still exists in the States, but in other countries, if other countries are listening in, we use it for very severe pain. It is better than morphine or anything, by mouth or injections against a very acute, super painful crisis. Oxygen, as talked about, against the migraines and against muscular pain, and then fatigue and so forth. Codeine seems to be useful, not in everyone. The very nice thing with EDS patients is that they are highly sensitive and they can find out themselves what works for them, what doesn't, and how they support things, and the physician needs to listen. Global cryotherapy, as is being developed, is indicated. Ketamine sometimes works, sometimes doesn't. It's not the best. Low dosage NSAIDs are still okay. The bleeding risk there is low, but we do prefer acetaminophen, which is paracetamol, just simply because there's no bleeding risk associated. Relief pain. Yes, neuropsychological comportamental treatments like hypnosis and relaxations are just simply treatments that should and can come on top. It is simply a medication that you can do without having to take another medication that goes through the whole body. And it's a very good thing to learn. Tai Chi Chuan, as talked about earlier, teaches the brain to know where the body is in space and time. I have found I react extremely to most medications, is written here. Sometimes with opiates and antidepressants result in suicidal reactions. Is this common in EDS? EDS can have very extreme reactions, as in I don't react at all to it, to I react a lot to it. And it can be different from day to day. It can happen. And if you want to try nifopam, the point is anything can have a similar effect, and it could also not. That's the problem about EDS. So other useful treatments. Melatonin, we get 4 milligrams, which is not what you get over the counter. I think over the counter most of the time you get 2 milligrams, so you just take 2. Light therapy to get day and night cycle back. Gastric reflux, omeprazole, or any PPI is important because there are so many pain medications that increase bleeding risks, and the bleeding is high anyway, so we give it quite often. Allergies via mastocytes seem to have some association, so it should be asked about. Sometimes there's an unstable bladder and there's sweating, so Vesicare and Ditropin can be used for that. There's a contraindication, which is glaucoma. Dysautonomia, which is what Professor Bravo told us, Professor Bravo in Chile, an amazing professor, came up with using fludrocortisone, 0.1 milligrams per day, against the dysautonomia, and I think he's the one who's actually seen more patients than Professor Hamonet, and it seems to work very, very well, and we are about to start using it here too. Then Professor Bravo, Professor Hamonet, and Dr. Chopra all use vitamins and those kind of substitutions to give support to the mitochondria, which are our cells that make energy, to fight the fatigue, and try that out. That is over-the-counter stuff.
Sur les mitochondries, il y a aussi, bien sûr, les médicaments que nous avons prescrits pour la fatigue, qui agissent sur les mitochondries, notamment la carnitine, la L-carnitine.
So what we do prescribe nearly to every patient who scores high in fatigue is L-carnitine, as I talked about beforehand, which also works on the mitochondria because it gives it certain amino acids that the mitochondria absolutely need to produce energy. But all of these C complexes, ubiquinone, folic acid, and so forth are necessary for them to work. Vitamin D. Yes, everybody north of Sicily has most often a shortage of vitamin D, just simply because there's not enough sunlight, or we keep sitting in our offices and work inside the whole day. But EDS on top has a skin that might not be able to produce as much vitamin D from the sunlight, so we substitute with vitamin D not only in winter but also in summer. And as mentioned above, physical therapy, proprioceptive therapy. The physical therapists actually know what that is, and it needs to be isometric. Physical activity per se, and yes, sometimes painful and fatigue and so forth, but it is essential for the maintenance of proprioception. So the vicious cycle needs to be broken. There are some iatrogenic practices that shouldn't be used or should only be used in moments where one really thought about whether it is absolutely necessary. Anticoagulation, EDS, does have tendencies to bleed, any EDS, not only vascular. That does not mean that heparin is absolutely contraindicated. There's nothing that is ever absolutely contraindicated, but one should think about whether heparin is absolutely necessary or whether one can substitute with getting the patient out of bed earlier and things like that. Corticoids, interjoint.
Pour les anticoagulants, il y a évidemment des indications où ils sont absolument nécessaires. Et il ne s'agit pas de s'en priver. Le risque vital est souvent important. Mais il faut surveiller, être particulièrement prudent et réagir très vite.
So, anticoagulation, as I said, sometimes is necessary. There's no absolute contraindication, and then it should be given. But the point is that when the physicians thought about it and give it, they should then keep checking the patient very frequently because it's a balance thing. Corticoids and morphines we talked about, antidepressant we talked about, neuroleptics, orthopedic surgery and surgery in general only in a really, really good indication when it is absolutely necessary. And then yes, obviously it should be done, but one needs to think about it very well. And joint manipulations, especially in the neck, be very prudent about it. Hypermobile, and it can nick other arteries that are running along there, and we've seen some bad side effects. Very, very prudent. Then for some people, we have dog assistants, and we get them dog assistants to take off clothes, for example, and to carry things and so forth, and it's very helpful in decreasing the disability within their daily life. The preventive measures we talked about, ultrasound of the gallbladders and arterial Dopplers for everyone at least once. And just as a last small thing, French TV, they often show these contortionists, but they're not contortionists, they are patients that should be listened to and asked about their problems, and these problems should be addressed because it's not all in their head. So listen to your patient, he will do the diagnosis. Osler said that already in 1900 in the United States. Graham, the one from London, said it in Paris in 2016, and Professor Hamonet keeps saying it. I put down a small bibliography at the end of the slides for you to go through, but the easiest thing is to go on gersed.com, which is the research group, and on the professor's website, Claude Hamonet, where you have the whole bibliography. And there's one last thing for any medical physician, medical professional who is listening in. We are doing an online course that will start in January 2017 and it will go until June 2017. In France, there's a very nice system. It gives university diploma courses, which was given at the University of Paris, Créteil. These university diplomas are for 1 year or over the course of 2 years, or if you put it on block and do it quite frequent over half a year. They are more than CME credits. They actually give you a subspecialty and they make you a specialist for that special disease. For example, you can also do it on diabetes or on arthrosis or on EDS. And anybody who is interested is for medical professionals. only, but any medical professional, you can mail to Professor Hamonet and join the course. We would be delighted. We thank you very, very much for listening in. And
un très grand merci pour nous avoir écoutés. C'est un long voyage que nous vous avons fait effectuer.
Thank you also from his part for listening in. You've been through a long voyage of the last 1.5 hours, and we will then proceed to the questions.
Ce voyage, depuis des signes et des symptômes qui souvent, très souvent, trop souvent, passent inaperçus et retardent le diagnostic, ce voyage est parti de ces signes pour arriver à des propositions thérapeutiques où nous espérons encore améliorer les résultats.
It has been a long voyage via signs and symptoms that are often not recognized or not even asked for by the physicians, via the possible treatments, and we are still searching for new treatments, and we will keep doing that. Thank you very much for listening.
Thank you very much.
Thank you. Très bien, merci, Professor Hamonet. Thank you so much, Dr. Brock. This has been fabulous. I can't thank you enough for addressing so many aspects of EDS that sometimes we don't hear as much about, that a lot of our attendees it's really resonating with them tonight, and just seeing your perspective is just so valuable. So we appreciate you guys so much. I'm going to go ahead and see if you have time to look at the questions. We do have some questions that were submitted during your presentation. If you're able to open the Q&A box at the top.
We are looking at many EDSers who have CCI and tethered cord and Chiari here in New England and across the US. It's a common comorbidity in France as well. We have started looking into it. We have a neurosurgeon, Professor Freddy, who is working with us, who does functional MRIs, and we have started looking into that as well. It's not a coordinated system in the US to treat EDS. Is it better in France? It's getting there, because we have these two courses where we actually teach the physicians in France and sometimes from abroad on what treatments are available and can be done. Is it coordinated? No, maybe not yet.
Je peux répondre?
Oui, bien.
D'accord. Alors, question sur mail. Curious mail.
Is there a way to help? Est-ce qu'il existe une façon d'aider les patients SED avec la douleur en France, par exemple le marijuana?
Alors, il existe beaucoup de manières de traiter les douleurs dans le syndrome d'Ehlers-Danlos.
There exist a lot of different ways to treat pain in EDS.
Les bonnes et les mauvaises manières.
They're good and they're bad ones.
La réactivité des personnes avec l'EDS, IDS, est particulière vis-à-vis des médicaments.
The reaction of EDS patients to medication is very particular.
Il faut donc être prudent et bien choisir le médicament.
So one has to be very choosy in which medication to take.
Nous avons présenté ce que, personnellement, j'imagine le plus efficace et le moins dangereux.
So the point is to find for each patient the most efficacious but non-dangerous one.
Bon. La question est la marijuana. La marijuana est actuellement interdite en France dans ce type de pathologie.
Marijuana at the moment is not allowed to be used in this form of pathology in France.
Elle commence à être autorisée dans d'autres types de douleurs.
It is starting in France to be authorized in other pain diseases.
Il se trouve qu'un certain nombre de mes patients l'utilisent ouvertement ou secrètement.
Some of our patients do use marijuana officially or in secrecy.
Ce que je peux dire personnellement, c'est que dans une longue, très longue expérience de médecins traitant des patients qui souffraient beaucoup,
What I can say from a very long experience as a treating physician for patients that suffer a lot,
je n'ai jamais rencontré de patients souffrant autant que ceux qui ont le syndrome d'Ehlers-Danlos.
I have never encountered patients that are in as much pain as patients that have EDS.
Ce n'est pas à moi de décider, comme médecin, si la marijuana ou autre sont à indiquer dans ces cas. C'est un problème qui est à la fois, j'oserais dire, politique, éthique, moral, autant que médical.
It is not up to me as a physician to say whether marijuana should be used or not. It is a political, ethical, moral, and then also medical question.
Je pense cependant que le cas des personnes qui ont ce syndrome et qui souffrent énormément, sans qu'on puisse les traiter avec nos médicaments, doit être examiné avec attention et humanisme pour pouvoir leur proposer autre chose. Pourquoi pas cela?
It is therefore that when the medications we are using to treat the pain are failing, these patients should be looked at with humanity, compassion, and other treatment options should be found. Why not also that one or any other that is actually working?
En tout cas, la question mérite d'être examinée.
In any case, the question merits to be examined. Ça on a dit, ça on a dit, ça on a... Is L-cross like spinal q?
Encore, Chiari,
J'ai dit que oui, Freddy. Alors, regarde, est-ce qu'il existe un système coordonné pour le plaid en France, apparemment? Est-ce que L-cross is like spinal q rest in the US? Est-ce que L-cross est comme la spinal q rest dans les États?
Alors, je peux répondre sur est-ce qu'il y a un système coordonné organisé en France? Je crois qu'il faut répondre non et qu'il est urgent de regarder cette question. D'ailleurs, j'ai rendez-vous avec quelques autres à l'Assemblée nationale, Commission des affaires sociales, très prochainement. Il y a beaucoup de malades. Vous voulez traduire?
Oui, merci. Sinon, je peux pas mémoriser. Is there a coordinated system in France? The truthful answer is no, not really. It needs to be urgently addressed and optimized, and he has an appointment with other physicians at the National Assembly in France very soon.
En effet, il y a beaucoup de patients, jamais ou presque ils ne sont diagnostiqués.
There are, in effect, a lot of patients that are never or diagnosed.
Beaucoup de faux diagnostics sont posés avec de vrais traitements dangereux.
A lot of false and misdiagnoses are being made, and treatments are started that are actually dangerous for EDS, and they are being started because of the misdiagnosis.
Pire encore, ces patients sont mal considérés par les médecins qui, quelquefois, les traitent avec un certain mépris, ne les croyant pas, les soupçonnant de raconter des choses fausses parce que les médecins ne comprennent pas.
Even worse, often patients are being thought of as saying whatever, and the physicians do not believe them, just simply because the physicians don't understand.
Il est donc important de disposer de médecins bien formés, de spécialistes bien formés et de lieux d'accueil, mais aussi de soins. Et il y a un travail énorme à faire, mais je crois qu'il est mondial.
It is therefore very, very important to teach and to train physicians in EDS. There's a lot that needs to be done. I'm paraphrasing here because I couldn't remember the whole sentence. I'm very sorry. There's a lot that needs to be done in teaching and training physicians the correct way about EDS. This is not a French problem, it's a global problem.
Quant à la coordination des soins, de l'insertion sociale, nous avons essayé avec nos moyens modestes de créer un tel réseau et nous essayons de le développer, mais nous devons être aidés.
In order to be able to implement a coordinated system and helping, we have started to teach and train physicians, but it still needs to get better and we need help for that.
Je terminerai en disant que le seul système très modeste qui existe en France est destiné à une maladie rare. Le syndrome d'Ehlers-Danlos est une maladie fréquente, j'affirme.
Encore une fois.
Le seul système organisé que nous ayons en France, qui est très modeste, ce système,
this very modest and small system that we have been able to organize for EDS in France,
est destiné à recevoir des patients qui ont une maladie rare.
It's destinated actually to receive patients in the number of a rare disease.
Or, le syndrome est une maladie fréquente.
But EDS is a frequent disease. Okay. Across spinal pubis in the US, we don't know.
Je peux dire.
Oui.
Je ne connais pas la ceinture américaine spinal west.
We don't know the spinal Q-West in the US, so we don't know whether it's like L-cross.
Mais peut-être elle se rapproche du principe des 3 points, 2 au niveau des épaules, 1 en bas du dos, de la ceinture qu'on a appelée, qui s'appelle L-cross. C'est le nom espagnol.
But maybe if it approaches the same underlying system, which is the 3 points, 2 points at the shoulder and 1 at the lower back, that would go into the same direction as L-cross from Spain.
Qu'est-ce qui semble mieux
pour des patients
qui souffrent d'anxiété et de dépression? Alors, je pense et nous sommes plusieurs, le professeur Boulbena en particulier, à Barcelone.
He thinks, and we are quite a few that think that way, especially Professor Boulbena from Barcelone, Spain.
Que beaucoup de patients qui ont le syndrome d'Ehlers-Danlos sont anxieux.
That many patients that have EDS have anxiety.
Par contre, ils ne sont pas déprimés.
but they are not depressed.
Pour la plupart.
For the most part.
Ce que je constate actuellement en faisant passer systématiquement des tests d'anxiété, de dépression, à mes patients en consultation.
Which is a study that we have actually just started, giving out depression questionnaires to the patients that are coming to our consultation, and we do not see a lot of depression.
Au contraire, ils sont très, très actifs, très volontaires.
On the contrary, they are actually very active and
Volontaires. Entreprenants.
And have a great entrepreneurship.
Ouais. Mais beaucoup de médecins confondent anxiété et dépression.
But there seem to be a lot of physicians that confound anxiety with depression in EDS.
L'anxiété est plutôt pour moi une qualité, car elle nous prépare à prévoir l'avenir et à mieux affronter le présent.
Anxiety for him is actually more of a positive feature because it prepares us to see and prepare for the future. Si symptômes en présenté à la publication, on avait parlé, vous voulez que je réponde?
Oui, mais les symptômes sont plus fréquents à la puberté.
But the symptoms are more frequent at puberty.
Ils sont en effet très sensibles aux hormones féminines. Puberté, grossesse, après accouchement.
Tu vas parler de Compressive? They are actually very sensitive to the hormones at puberty, during pregnancy and labor, and during menopause.
Ils ont particulièrement été étudiés dans le cadre de notre réseau, notre petit réseau, avec une professeure de gynécologie qui est de gynécologie, la professeure Gompel.
They have been studied in our little réseau of 3,000 patients by a gynecologist, Professor Anne Gompel, who sees all our female EDS patients.
Elle vient de publier dans une revue américaine de génétique un article sur plusieurs centaines de patients qu'elle a suivis et qui est très descriptif de ces symptômes.
She has just published in an American genetics review the study she's done on several hundreds of patients that she has followed, where she's describing a lot of these symptoms, the gynecologic problems, and the treatments she is prescribing.
On parle du Canada, de Montréal, je connais bien parce que j'y ai travaillé et j'ai beaucoup d'amis, notamment une généticienne.
There is, when we talk about Montreal in Canada, he has a lot of friends there, and especially one friend who is a geneticist.
C'est Gail Ouellet. Gail Ouellet, O-U-I-L-E-T-T-I, voilà, Ouellet, qui est la présidente d'une association, d'un service qui prend en charge toutes les maladies héréditaires au Québec.
Gaël Ouellet, O-U-I-L-E-T-T-E, is the president of an association that is in charge for the whole of Quebec.
C'est pas une association, c'est un service spécial. Ouais.
It's a specialized service for rare diseases, all the rare diseases in Quebec. So you could go to her. What is the mechanism for severe exertional dyspnea and generalized muscle weakness in EDS? The mechanism seems to be proprioception, that is inspiratory bradypnea, which means the the muscles need to work in an absolute concert to be able to breathe in perfectly well, and they are more chaotic than they should be, and that leads to dyspnea. The generalized muscle weakness might have to do with an extraction of oxygen problem, and with the fact that if you don't know where your body is in space, you need to put in a lot more energy to actually combat that problem, and therefore you dispense more energy.
Je vous ai expliqué tout à l'heure que l'oxygène était très efficace sur justement ces difficultés respiratoires.
As we've talked about earlier, that oxygen is very helpful for these dyspneas.
Oxygène en prise quotidienne.
Oxygen when taken daily. Yes, pulmonary function testing is within normal limits in EDS, and still they have dyspnea. We see that too.
L'hypotension est fréquente, mais pas si importante que cela, dans le syndrome.
Hypotension is frequent, very severe hypotension, not so much, but hypotension is frequent.
Le cœur au repos peut être ralenti, 40 ou 50 pulsations par minute, ce n'est pas exceptionnel.
Tachycardia can come even when the heart is normally and addressed. It is not very exceptional.
Il y a souvent des malaises difficiles à interpréter, POTS, hypotension. Ce n'est pas facile, mais c'est relativement fréquent dans ce syndrome.
There are these features like POTS or hypotension that are hard to interpret in EDS, but they are very frequent.
Ceci est dû à la dysautonomie, la dysautonomia.
And this is due to the dysautonomia. Professeur Bravo traite avec le plus.
Oui, par exemple, mais aussi l'oxygène.
Ah, okay. which we treat with oxygen, and Professor Bravo treats with fludrocortisone, and maybe the combination of it.
Je ne me sens pas compétent pour parler des mutations génétiques. Je ne suis pas généticien. Mais vous allez entendre le professeur Castori bientôt, qui est un ami, un bon ami, un grand ami, et qui est un excellent généticien clinicien, qui pourra vous parler et vous répondre.
In 2 weeks, you have Marco Castori, who is a great geneticist and genetical clinician, who will talk in 2 weeks on the 15th, I think, who can absolutely answer all of these genetics questions.
On parle des différents types de syndrome d'Ehlers-Danlos. Je pense que on devrait moins se préoccuper de cela, parce que la forme la plus fréquente, celle que je vous ai décrite, représente la quasi-totalité des formes rencontrées. Les autres formes, ces autres formes, peut-être traduit.
Because we come from a treatment point of view, his answer is that the most common form we see is EDS hypermobile type, and that is because treatment is symptomatic. We're not very concerned with all of the different types of mutations at the moment, because it's symptomatic treatment for all of them anyway.
Il y a des formes très très rares, avec quelques tests génétiques plus précis.
Oui.
Il y a des formes très très rares qui se rencontrent beaucoup moins souvent.
There are very rare forms, which we therefore also see not very often.
Et qui bénéficient des mêmes traitements.
But who benefit of the same treatment.
La dyspraxie du langage est une des manifestations qu'on peut rencontrer dans de dyspraxie du langage est une des manifestations que l'on peut rencontrer dans le syndrome. De même que la dysorthographie.
Dyspraxia is actually something we encounter often in EDS, more often than dysgraphia.
Les effets de l'oméprazole avec la question d'utiliser un médicament
si on utilise l'oméprazole
à long terme,
oui. Est-ce qu'on doit prendre les vitamines à un autre temps dans le jour même parce que l'oméprazole inhibite l'absorption des vitamines?
La question des vitamines et de l'oméprazole ne se pose pas vraiment, dans mon expérience en tout cas, ni celle du gastro-entérologue de notre réseau. Les effets à long terme des antiacides gastriques ne se posent pas dans notre expérience ni dans celle de gastro-entérologue du réseau.
Side effects of omeprazole and long-term side effects have not been seen in our patient encounters and not in the gastroenterologist encounters of our research group.
Il pourrait s'agir de la vitamine B12. Il pourrait s'agir de la vitamine B12.
It could be that B12 is absorbed as well.
Je pense qu'il est intéressant de prendre beaucoup de vitamines dans ce syndrome, mais les avantages du traitement par les antiacides est énorme, à cause aussi des reflux vers l'arbre respiratoire.
He thinks it is very important to take different vitamins for EDS, and it's a good thing, but PPIs like omeprazole are actually combating and helping a lot in combating the reflux in EDS, which also alleviates other symptoms in all of the respiratory and tracheotomy. Yes, you patients are in a difficult position to tell the physicians what you've heard. En forme écrite. Donc, nous ne pouvons pas dire ces médecins que vous ne connaissez pas, ils disent. Ouais. La question, c'est qu'est-ce qu'on fait en tant que patient pour parler avec les médecins parce qu'eux, ils ne savent pas.
Non, une réponse personnelle. Ce que nous avons essayé de faire en France,
what we have tried to do in France,
c'est de donner des recommandations aux médecins pour mieux traiter leurs patients.
Is to give recommendations to the physicians to better treat their patients.
Nous pouvons envisager de traduire ces recommandations en anglais.
We are about to translate these recommendations into English.
Et de les diffuser plus largement.
And to diffuse it more largely.
Voilà. Ceci est important quand on arrive aux urgences.
Which is very important when one comes into the ER.
Ou quand on propose un traitement contre-indiqué.
Or when one is proposed to get a treatment that might be contraindicated.
Ou un geste diagnostique.
Or doing
trying
to diagnose something.
Comme une coloscopie ou une ponction lombaire qui sont contre-indiquées.
Like doing a colonoscopy or a lumbar puncture, which are contraindicated, not absolutely contraindicated, but
Est-ce qu'il y a d'autres là?
Moi, je peux répondre à ça
Alors,
parce
ça,
que je
la
viens de
question-
le lire. Je viens de le lire, je peux répondre à ça
Allez-y.
parce que je viens de vous le dire. Where are we? In the US recently, alpha tryptase excess has been linked to hypermobility. Is that a reasonable link? I have just read that research a few weeks ago too. I find it very interesting, and they don't seem to have enough patients. And I talked to the professor about it, and the thing would be, I think what you're talking about is the NIH publication, and he has given his okay for me to write an email to them because we have the patients and they seem to have the alpha tryptase, and to look into that.
Pour toutes les recherches biologiques, alpha-tryptase, la génétique, vous aurez un interlocuteur excellent qui est le professeur Castori, qui doit intervenir bientôt.
But for all the genetic questions, you have an amazing doctor coming in 2 weeks, which is Marco Castori. How can I help my active family with progressive disease and joint? The braces and limitations of movement, that would really be the compressive garments and the big orthesis we talked about. And if it doesn't help at all in the US, and you can't find a way to do it, the only thing would be then try and come here. But yes, I hope you find a way to do it in the US.
La malformation d'Arnold-Chiari est très rare. Les signes d'orientation peuvent être des douleurs particulièrement importantes du cou, mais il ne faut pas attendre ces signes, je crois, pour rechercher un Chiari ou Arnold-Chiari par une radio simple.
Arnold-Chiari malformations are rare in EDS, and a symptom might be that there's a lot more pain in the neck than in other EDS patients, but we don't think that you should wait for these symptoms to actually check for Chiari. Everybody should be checked for Chiari.
Il y a encore d'autres.
Je
comprends la souffrance d'une maman ou d'une personne qui voit ses enfants ou des membres de sa famille qui progressivement voient leurs articulations plus douloureuses se luxer, moins bien fonctionner et qui ont du mal à marcher.
We understand the suffering of a family member who sees their family members suffering more and more from luxations and subluxations and loose joints.
Les traitements que nous avons proposés, notamment les orthèses, permettent d'améliorer cette situation. Je m'aperçois d'ailleurs que dans cet exposé,
the treatments that we have proposed in these slides, the orthesis and the garments,
je n'ai pas parlé d'un traitement très simple. Ce sont des sièges, des dossiers, des matelas à mémoire de forme.
He would like to amend two treatments that we also use, which is cushions and mattresses that are made out of memory foam to be able to sit longer on chairs and to sleep better at night.
Ils rendent de très grands services à la quasi-totalité de nos patients, à tous nos patients.
They are a great service to all our patients.
Ils sont faciles à trouver.
They're easy to find
anywhere.
Je crois que c'était tout.
Non, c'est tout. C'est tout.
Thank you very much for all your questions, and thank you very much
thank you for very interesting questions.
And thank you for the very interesting questions.
Voilà, vous parlez anglais comme moi.
Ah oui, je parle anglais comme vous.
C'est bien.
Merci beaucoup. Thank you so much, both of you. Oh, what a wonderful presentation. You were able to cover so much detail and did it wonderfully, and we appreciate you so much. We appreciate your compassion for all of us on behalf of all the patients that are listening live today and the ones that are will be watching the recording. I can't
remember so much. 1 second, I have to translate for him. Merci pour la présentation très détaillée. Merci d'avoir autant de compassion pour nos patients. Et I think you said a lot more, and but thank you.
And tell him we welcome both of you back at any time. If you have more information to share with us, we are just thirsting for information. And some of the things you covered, we just have not heard enough about yet. And we are just so appreciative of that.
Et si jamais on a d'autres informations ou on veut parler encore une fois, elle serait heureuse de nous accueillir. Et il y en avait des informations là-dedans qu'ils n'ont jamais entendues et c'était bien pour nous.
De toute façon, il est possible que nous puissions correspondre par Internet, si je trouve le temps de répondre à tout le monde, mais avec plaisir.
If ever, it would be his pleasure to correspond via Internet. Finding the time, as always, but it would be his pleasure to help.
Vous avez mon adresse sur le site et vous avez l'adresse qui vous a été donnée à propos de la formation en ligne que nous mettons en place à partir de lundi, où vous êtes les bienvenus.
And you have his address, mail address here, and anybody, medical professional wants to join for the formation online, which means that might be, Brock Adler, also a way to do it. Get your physicians to join the program, then they learn, maybe. Anyway, anybody is welcome to join that or write an email.
Thank you. Oh, that's going to be very valuable for everyone internationally to participate in that. Thank you for doing that, putting that together. And is there anything else that you would like to say as we start to close the meeting tonight?
Il y a quelque chose d'autre qu'on veut ajouter?
Non, nous avons beaucoup parlé, je pense, et c'était très intéressant pour moi aussi.
Thank you. I think we talked a lot, and it was very interesting for us to receive your questions, and thank you for that. And thank you for having us.
Bye.
Thank you very much for your time and your experience and your great contributions to our community.
Yeah, we will be posting the recording of this webinar by the end of the week. So please come back and visit. And you can also post it on Facebook or other locations. We will be posting the slides as well. And Dr. Brock, could we post the French slides as well so that we have both the English and the French? That'd be great. Okay.
Yeah, the French slides from beforehand, or you mean all the grammatical errors I made in the English slide?
Whatever you'd like to provide, we will post on our site so that people have the information available. So, but we will definitely post these slides on our site. So, again,
I think there's some typos in there. Can you make them nicer?
Yeah, whatever information you'd like to share. We can put links on our site. We already have a link out on our site, so we certainly appreciate that. There was a mention of pillows and wedges and mattress pads, and just to put a little commercial in, those of you in the U.S., Body Support Store has a wide variety of over 250 products, including wedges and mattress pads and the like for those with EDS. So they've been selected by EDSers for EDSers. So please go out and look at our website.
All of those proceeds go to support our program. So that supports the nonprofit program. And also wanted to remind you that Dr. Castori will be speaking on the 22nd. So mark your calendars for that. That will be at 1 p.m. Eastern Standard Time in the U.S., which is 1900 CET in Europe.
So again, thank you all for joining.
And he's amazing.
It was amazing. So
Marco Capponi is amazing.
He is. I met him at the international conference in May, and he's very gracious and very, very knowledgeable. So we're looking forward to that presentation. So thank you again. We'll call it a day. We appreciate those that have attended and the presenters for today. So have a good weekend. Thank you. Bye-bye.
Bye-bye.
Bye-bye. Thanks.
Thank you. Good night.
Thank you.
Good night.
Good night.
Good evening. Good night.